Morning, everybody. So we're going to switch gears just a little bit. I work at Temple, and one of my focuses is on procedural education. So I wanted to give a PK talk about a procedure. So we'll get started. This is the plan, the outline for my 6.5 minutes left here. The first thing I want to do is take a quick audience poll. Just by a show of hands, how many of you are regularly using percutaneous or small bore catheters to treat pneumothorax? Okay, so maybe a little bit less than half the room, which is kind of what I expected. There's not a lot of evidence out there as to these numbers. There's one study that was done in France a few years ago that shows about 50% of ER physicians are using small bore catheters regularly as their first line intervention for pneumos. So we'll talk about spontaneous pneumothorax and the evidence for small bore catheters. We'll also talk briefly about traumatic pneumos. And then I'm going to go through a quick tutorial for those of you who aren't doing this regularly. And I think that there's probably a twofold reason for why people aren't using these small bore catheters. And one reason is probably because you may not be familiar with the evidence and whether or not this is actually the right thing to be doing. And the other reason is probably from not having done it a number of times. So we'll kind of quickly go through how to do that. So there's an article here, this new, less invasive method for draining pneumos, this like hip new thing. Yeah, the article's from 1993. This is a 25-year-old article. But even as recently as 2014, there's a blog post on EP Monthly online telling people how to do this. So it's clear that this isn't really catching on, and our hand-raising poll in the room kind of confirms that people aren't doing this, even though we've got literature from a couple decades ago. Of course, we have concerns when we place any size chest tubes. The failure rate is probably high on our concern list, particularly when we're thinking about using small bore catheters. Is this actually going to work, or am I just wasting my time and the patient's time here? How long is it going to take? Is it going to take longer for a small bore chest tube to drain the pneumo than a large bore chest tube? And of course, correlating hospital stay length. How long are they going to be in the hospital with this? Complications, infection, damage to surrounding organs, needing to go in and do another procedure later, i.e. upgrading to a larger gauge chest tube. And then procedural discomfort, which we're not going to talk a lot about because this is kind of a no-brainer, right? Using these small bore catheters is obviously less painful than shoving a giant chest tube into somebody's rib cage. So let's quickly go over the evidence for spontaneous pneumos. This is a study from not too many years ago comparing the two, a pretty good number of patients, 212. And this study showed that both the failure rate was equal between groups, and the duration of drainage is actually shorter in these small bore catheters. Another study, and this is very recent, has a huge number of patients because it's a meta-analysis looking at a number of studies comparing the two. Again, the failure rate is equal between both groups, but everything else is in favor of using these small bore catheters: hospital stay, duration of drainage, and the complication rate. And of course, we don't need to discuss this with every case, but procedural discomfort is obviously much better for these smaller gauge catheters. Finally, it's not just us looking at this. We want to know what our colleagues, our consultants think about this, because these patients don't live in the ED forever. This article from the thoracic surgeons and this article from our pulmonology colleagues, 273 patients respectively, and they're in agreement. The failure rate is the same between both groups, and at least their literature is suggesting that they think that these small bore catheters can be the primary intervention for primary and secondary pneumothorax. And most of the literature that's out there is showing that it's true for primary, secondary, and iatrogenic pneumos. So the bottom line for spontaneous pneumos is that the evidence is convincing. It's probably not dependent on your consultants or your hospitals for these. But it should be a conversation you have with your pulmonologist, because even now when I place these, my pulmonologists seem a little bit surprised when I call them with it. So it's something that you should put on their radar. Moving on to traumatic pneumos. Quick article here, pigtail catheters for traumatic pneumos. Two different groups, but the demographics of both groups were the same. So they were using them equally on both groups that they studied. The duration of drainage and the complications were the same, but there was a slightly higher failure rate in the patients who got the small bore catheters. This wasn't statistically significant in this study, but 11% versus 4% was there. This is an interesting study to me because it's done by the trauma surgeons and their primary endpoint was pain. This has not been my personal experience when dealing with trauma surgeons. Not surprisingly, there was less pain at the insertion site when you put a small gauge catheter through somebody's chest wall, but they found failure rate and complications were the same in both groups. And then finally, this is a 7-year study. They also agree with me that size doesn't matter at the end of the day. It's a lot of patients, and they found, again, failure rate, complications, and initial drainage output, which we know that surgeons love, was the same for both groups. That being said, the demographics of their groups were a little bit different because they were able to select, it wasn't randomized, so the end conclusion of this study was that more study was needed. So evidence is pointing towards smaller gauge chest tubes. It may be dependent on your hospital, and again, you need to talk to your consultants about this. So briefly, there's 2 types of kits. One of them uses the Seldinger technique, and the other one has a catheter directly over the needle. Like any procedure, you need to have your prep work done. This is sterile. You need lidocaine if it doesn't come in your kit, and you should be giving these patients analgesia or anxiolysis because even though you're putting in a smaller catheter, it's still uncomfortable. And have your Pleurovac set up. Not that that's ever personally happened to me that I got the chest tube in and realized I didn't have a Pleurovac set up, but go ahead and do that so you're not standing there with your finger over the chest tube. The Seldinger technique here is just like every other Seldinger technique, straightforward. You're going to, of course, clean the area, drape, numb them up, but the needle goes in, the wire goes through the needle, and then you take the syringe and the needle off, and you'll need to nick the skin for this catheter. The catheter over the needle technique, and this picture is just to show that you can do this anteriorly as well as laterally. The catheter's already on the needle, so you'll need to make a nick in the skin immediately when you start the procedure, otherwise that catheter isn't going to slide over. And you'll just start to pass the needle in until you get a rush of air, and then go ahead and push the catheter all the way in. There's a piece of extension tubing here that attaches to the end. It's not very intuitive. Go ahead and open your kit and look at it and figure out how everything goes together because it doesn't make sense when you open the kit and the pieces don't all come together. And then finally, just like a central line kit, these need to be secured. So you're gonna sew this on, kind of zoomed in here in place, and then put a sterile dressing over the whole thing, and then you're done. Of course, you're going to need a chest x-ray to confirm placement. With these, you need to remember, because it's a flexible catheter, when you look at your chest x-ray, you're going to panic and think that you put it in the soft tissue, but it might actually be pressed up against the chest wall by the lung because you did such a great job, okay? So don't panic when you look at that initially. Some of these patients will go to the inpatient floors. Of course, some of them can actually go home with a Heimlich valve if they have great follow-up and they can get in to see their PCP who's not terrified of what you've done to them. At Temple, we admit most of these patients to the floors because they don't have primary care doctors. So wrapping up, we know this is quick, this is less painful, these patients have an easier disposition. It should be, based on the evidence, your first line treatment for treating spontaneous pneumothorax, and you really can consider this pretty strongly in treating patients with traumatic pneumo. If this isn't something you've done before, it's not something you're that comfortable with, I strongly encourage you to go home, rip open a kit, waste that money, and get comfortable with the kit, putting everything together before you actually get to do this with a patient. Any questions?